Hi there, and welcome to the session called Caring Contacts, Suicide Prevention and Screening the One Medical Way. I'm excited to have you here. I'm Andrew Bertagnolli. I'm a clinical psychologist and the National Clinical Director for Virtual Behavioral Health Services here at One Medical. I sit in San Francisco, and I'm excited to be here with my colleague, Dr. James Lyda, who I'll let him introduce himself, to tell you a little bit about what we're doing around suicide prevention.
Hi, I'm James Lyda. I'm a licensed psychologist. I'm a virtual medical director here at One Medical on our virtual behavioral health team, and I sit in Rochester, New York.
Great. Thanks, James. So wanted to just highlight the issue. We are wanting here at One Medical to do a better job of identifying and preventing suicide. Our solution that we're proposing is Caring Contacts by One Medical, part of our Mindset program. And what we're going to talk to you about today is what it is, how we did it, and some lessons learned. But before I get started, I always like to acknowledge the team that actually does the heavy lifting and the hard work. So here's a subset of our virtual behavioral health team that's dedicated to this program. They work across all 50 states and U.S. territories to help give our members a uniform experience with regard to the suicide risk assessments and safety plannings. More on their work to come. As we orient, just want to tell you a little bit about One Medical for those of you that may or may not be familiar with One Medical. We're an advanced primary care practice with fully integrated care modalities. We are located, we have various clinics. So we have our on-site clinics, which are embedded in employers' wellness centers on campuses. We also have near-site clinics in communities, maybe one near you. And we also have a virtual care component as well. In terms of our locations, we're located throughout the United States. You'll see a map here. We have both our One Medical offices that are adults and families, and then we have specialized clinics that are focused on the senior population as well. And the program we're going to describe today covers all of our members, no matter where they are in the One Medical geography. So what are we really doing? So One Medical has been developing a suite of behavioral health related services centered around primary care in order to better identify, manage, and treat common mental health conditions that we see in primary care. We have an array of offerings that span the gamut from low intensity interventions, some brief therapy, coaching, collaborative care. We also have a crisis line that we use that's in-house. And what we're going to talk to you about today, however, is our behavioral health screenings. We feel that that's really the part that fits best with suicide risk assessment.
So, as Drew mentioned, the problem that we're addressing and the challenge that we're facing is the issue of suicide and suicide prevention. So we know that suicide rates have increased at an alarming rate over the last 20 plus years, including increasing yet another 2.6% in 2022. And according to the NIMH, suicide is the second leading cause of death in people ages 15 to 34 and the 12th most common cause of death overall. So as a primary care organization at One Medical, we know that primary care is the most likely point of contact for suicidal patients in the healthcare system. 3/4 or more of patients who die by suicide have presented to a primary care in the year prior, 45% or more presenting within a month prior to death. There are a lot of advantages of primary care, accessibility and availability, established relationships, opportunities for education and awareness and earlier intervention. And when integrated with mental health, behavioral health services, it only enhances the effectiveness. So an important component of our screening process and across the healthcare system, and particularly at One Medical, is the PHQ-9, or the Patient Health Questionnaire 9. And this is a diagnostic tool introduced in 2001 to screen adult patients in a primary care setting for the presence and severity of depression. So patients rate themselves on a 0 to 3 scale for each item of the PHQ-9, and a score of 3 indicates or higher severity for each question. The ninth question of the PHQ-9 asks, over the last 2 weeks, how often have you had thoughts that you would be better off dead or hurting yourself in some way? So we know that elevated response to this ninth item are associated with higher risk of suicide, and higher scores are associated with higher risk. But the overall predictive value of the PHQ-9 is a bit unclear. It assesses both passive thoughts of death and the desire for self-harm in a single response item. And what's really important is that it shows increased risk over weeks and months, not hours. So its intended use is not for immediate crisis intervention, but it gives us a sense that as a patient may need to have follow-up and be screened further for suicide and suicidal ideation. So this just gives you a bit of snapshot of kind of what we see at One Medical from the ninth item of the PHQ-9. So our standard of care is to reach out to all patients who endorse suicidal ideation on the PHQ-9. And for those who have the highest severity, we further take this further and engage them for risk assessment. So we wanted to leverage our primary care touchpoint and integrate the expertise of our behavioral health specialists using our technology-driven and human-centered approach. So our goals and objectives were to ensure clinical quality in this process, to increase our clinical effectiveness, in particular by adding and teaming our behavioral health specialists with our primary care team, and to increase overall patient safety and satisfaction. So we decided to put our technology-driven spin on caring contacts, which has its roots actually way back in the 70s. So caring contacts is an evidence-based suicide prevention intervention involving care teams sending brief messages expressing unconditional care to patients at risk of suicide. It's listed as a best practice by the Zero Suicide Institute. And at One Medical, we leverage our technology to screen PHQ-9s and also Edinburgh postnatal depression scales, which is similar to the PHQ-9. And we deliver caring contacts messages and initiate risk assessments when indicated using our technology. So what we have is an automated workflow that's built into our electronic health record and our systems, and it works in this way. So we have actually algorithms built in to our EHR, which identifies patients who have diagnoses that are depression diagnoses or depression relevant diagnoses, and also can indicate and filter patients who have not received a PHQ-9 in a certain amount of time. Our system will automatically push out PHQ-9 to those patients and using with the One Medical app. PHQ-9s can also be ordered manually by our clinicians, depending on the need, whenever necessary. So at that point, a patient can complete the PHQ-9 in the app, again, using our technology. And when they do so, when they complete the PHQ-9, a pop-up displays that thanks them for completing the PHQ-9, and also gives them information about our crisis line, and then submits our results to the system. Letting the patients know about the crisis line and that exists and crisis information right away, regardless, is an important piece of this, because it provides them with that information before they even have any response from us in an automated way. But to add a human-centered touch to that, we take it further through our caring contacts process. So patients who are flagged as higher priority in our system when their ninth item of the PHQ is greater than 0. So the algorithms built into our EHR, again, are able to filter this, and it sends results to an urgent task queue, rather than directly to the primary care provider, who is maybe very busy, may or may not be working on that particular day. This allows our behavioral health team, or virtual behavioral health team, to monitor this queue and engage and respond as needed. So what you see here is a screenshot of this urgent task queue in our EHR. I'll have you note that these are not real patients, but our EHR relies on an algorithm to filter higher risk, high priority PHQ-9 responses. And from there, our behavioral health team can assess the patient's chart and access it and determine whether or not they need to be sent a caring contacts message. You'll note here in this image that the tasks, the items on this queue that are flagged indicate higher priority. So it's very easy and user-friendly to use and to indicate which patients may need response that we need to prioritize. So when we differentiate between level of severity in terms of our response. When a patient indicates a response of 1, or the lowest level of severity and endorsement of suicidal ideation on the PHQ-9, we send a caring contacts message to the patient through our secure messaging system. This encourages the patient to follow up with their primary care provider and includes information about our One Medical crisis line, as well as other suicide prevention hotlines. From there, we then send a follow-up, and we reach out to the primary care provider through the system and indicate that that patient has completed a PHQ-9 that has indicated suicidal ideation, and we let the primary care provider know that follow-up is necessary. When the 9th item indicates higher severity, so a 2 or a 3 in the response, we go a little further. So we still send the message to a patient, a caring contacts message, informs them, but this message has an added component where we inform them that a link will be sent to them through our app that will invite them to book a one-time meeting with a licensed therapist. This we also include information about our crisis line and other hotlines. The patient receives this link, and if they choose to, they are encouraged to schedule an appointment or meet with their primary care provider. If they choose to schedule that one-time appointment with one of our licensed therapists, we conduct a risk assessment. So it is not an initiation of therapy, but it is for the purposes of a risk assessment, and we use the Columbia Suicide Severity Rating Scale to guide that process. If through that process, we determine that they are a moderate or high risk, we create a Stanley and Brown safety plan with them that we also can share with the patient, and we will follow up with the primary care provider. So we let the primary care provider know through the system that what the results of that visit were, what that risk assessment, and we work with the primary care provider to coordinate follow-up. So this gives you a visual of kind of what our caring contacts invitation to a risk assessment visit looks like. There's some again, not a real patient here, but gives you an example. What you see here is some key components of what makes kind of the caring contacts, and that is, the initial introduction, an acknowledgement that they have indicated thoughts of suicidal ideation, and expressing our appreciation that they were open and honest with that, and then the invitation to meet for a one-time follow-up. And the instructions about how to go about scheduling that. Also, you'll see at the end, it includes information about crisis lines. So we really cover a number of bases in terms of giving the patient options and autonomy to decide how they want to follow up what resources they want to access, giving them the opportunity to have a human connection with a therapist to assess their risk and discuss further follow-up. So I'm going to pass it back to my colleague Drew to take us in a moment. But a couple things that I need to want to cover before I do that. One is we, as I mentioned before, we conduct a Columbia Suicide Severity Risk Assessment, and we use the Stanley Brown Safety Plan, and we also counsel on access to lethal means. This is a critical component of the mood, the follow-up visits that we complete, and we have a number of resources for our providers, for our therapists to access, to be able to make sure that they have the information that they need. This includes, because we operate across 50 states, we make sure that our providers have information that are as location specific as possible, and so that we can coordinate care. So I would be remiss if I didn't discuss the stakeholders involved in implementing this process. As you can see here, this gives you a visual of all of the teams, or many of the teams and departments that we had to coordinate and work with to make sure that the Caring Contacts process and this program was effective, was safe, was meeting legal and compliance. And so this just gives you a sense of kind of all of the moving parts, all the spokes on this wheel to make this happen. One area that I really want to emphasize, and that's critical in implementation of this process, is the behavioral health team and our frontline staff themselves. So it is really critical to have buy-in from them, and for them also to make sure that they feel they are trained and that we are ensuring the competence across our team to do this work. So what we do is we leverage partners who can provide continuing education and ensure that we are meeting a standard of care when it comes to suicide risk assessment and suicide prevention. And so to level set across our team, everyone engages with these trainings that you see here through our partner Psych Hub to make sure that we are providing the highest quality care and service. I think it's really helpful, and it's probably most powerful to hear directly from one of our providers, Felicia, who's a licensed psychologist, has been doing the Caring Contacts work since we implemented it in June of this year. Let's hear from Felicia.
My name is Felicia, and I'm a clinical psychologist at One Medical. I've been working in the Caring Contacts program for about the past 9 months. I'm going to share with you a couple of initial concerns I had about the Caring Contacts program and how those concerns compare to my actual experience. One of my initial concerns was that medical providers' understandable frustration and overwhelm at having to deal with patients who are at risk of harm to self or others. That understandable frustration experienced by the medical providers is now going to be directed in part at me, because I am now the mental health specialist who is involved. This concern has not been an issue with the Caring Contacts program. In fact, it has been quite the opposite. Medical providers have expressed appreciation for the coordination of care that I've done with their patients. I even had one medical provider recently disclose that this was the first time that he was having to deal with something like this, and we were able to have a constructive dialogue about the resources that he can provide to the patient. A second concern that I initially had was that the Caring Contacts patients would be highly demanding, and I would have ongoing obligations to the same pool of high acuity patients. This concern has not been borne out either. Caring Contacts patients do not become your therapy clients, and in fact, even the mood questionnaire follow-up visit is not a therapy session. That is made explicitly clear to the patients right from the get-go in writing and verbally. Because the Caring Contacts protocols are clearly outlined in writing and enforced and agreed upon by the stakeholders in our organization, it frees me up to be fully present and engaged with the patients. They express their appreciation and respond quite well to this highly structured, human-centered program.
Thanks, Felicia. We're super proud of the work that she and her teammates are doing in this, and I'm going to pass it on to my colleague, Drew.
Yeah, so just to kind of round us out here, the other pieces of the puzzle are the back-end monitoring at a population level and reporting capabilities that we're building out. So we are able here to look at the highest level, aggregate level, a list of patients who have had an elevation on their ninth item, the date that occurred. We also have some key information for the clinicians to look at that we know impact suicide risks. So alcohol use, drug use, if those are noted anywhere in the chart. The same with insomnia, and what you can't kind of see off the edge there is ADHD. We look for those comorbid diagnoses, as well as provide them with some age, gender, and ethnicity information, again, to help that clinician arrive at the right risk level. We also then are able to monitor this at a higher level with regard to how long is it taking us to turn these tasks around and outreach the patient. And here you'll be seeing some of our preliminary data that we're able to do this in about 54 hours from receiving the task back, or the PHQ-9 data back into our system. So again, as we continue to build and refine, we're looking at these as indicators of our success in the area. Additionally, the data we're collecting with regard to the visit utilization is shown next, which allows us to understand how many PHQ-9s are being sent out system-wide through a variety of channels. So that's clinicians sending them out, them being sent out by our population health colleagues to look at care gap fulfillment, et cetera. Since June, we've sent slightly over 12,000 PHQ-9s out, and a little over 4,000 have been completed. We're always looking at ways to increase our rates of returning the PHQ-9s. That's a different discussion. Out of those, we've had 140 patients who scored at the higher levels, so elevated risk of 2 or 3 on the ninth item. And about 43% of those have taken us up on our risk assessment visit, or our mood questionnaire follow-up visit, is how we talk about it from the patient perspective. What we've noted consistently is high patient satisfaction, high primary care provider satisfaction, as indicated in Felicia's video, and then also high behavioral health provider satisfaction. As a manager, that was one of my concerns, are the clinicians that I work with going to feel that it's a good use of their time? And overwhelmingly, they have agreed. So we're really feeling this is helping hit a kind of a win-win-win as we can see. And I wanted to just end with a patient story. And I like to end with the patient in mind, because that's our philosophy here at One Medical. And this is a gentleman that I actually met with. His name is Sam. He's a 48-year-old Southeast Indian male who had poorly controlled type 2 diabetes. He had PHQ-9 as a 20, and his ninth item was a 2. I reached out to him following the protocols that we just described, and he didn't respond for me for a few months, actually. But the order for the visit with me stayed active in the system, and then all of a sudden he booked it. When I got him on the phone, began to talk with him, doing the further risk assessment, moving into safety planning, I started to ask him about his alcohol use, and he said that he drank excessively. As I began to probe more deeply into that, turns out he drinks all day for the past 10 years, has lots of challenges with his labs. His liver values are way high, multiple failed attempts at sobriety. Did not really like to deal with primary care providers all that much. Spent the rest of my hour visit with him using some motivational enhancement and techniques, as well as some techniques borrowed from single session therapy. Was able to get him to agree to talk with one of our primary care providers about perhaps stopping his drinking. was able to go into our system and book him that right there when I had him on the call for a visit with a primary care provider the next day in one of our mental health visits. Those are specially dedicated visits for primary care providers to discuss mental health issues and concerns with the patient. Was able to quickly give the clinician who I was seeing, who I'd sent Sam up with, heads up about the visit that was pending. I gave her information around what Sam and I had talked about, also some key motivational factors that she could reference in her dialogue with him. And what was really nice is that he followed through with that visit, even though he told me he doesn't really like the primary care providers because he finds them annoying. He found Kathy, our primary care provider, not annoying, which was lovely. And she was able to get him to agree to start a program. He messaged back into me, thanking me for our time and that he really felt hopeful for the first time in a long while with regard to his drinking. And then he messaged in even further saying that he had initially a couple-week wait to get into the rehab facility, but the rehab facility had called and said that they had an earlier opening, and he jumped on that right away. So his story is still unfolding. I hope to join you at another venue to fill you in on what happened with Sam, but he is currently still in rehab, started at the beginning of the month of October here, and hopefully good things for him ahead. So in conclusion, just wanted to wrap up our process. What we did is we really began to think of this as an important issue, was able to get leadership alignment around the importance of the issue, but also wanted to stay true to our primary care-based philosophy. So how do we, as the mental health providers on the team, assist the primary care provider in better management of this condition? And what we found was really key was providing the primary care provider with the summary of the more in-depth assessment and plan, as well as providing them with actionable strategies on what they can do with this patient when they get them in their office, and rather than having the mental health provider take over the care entirely. So again, group effort to really look at developing the workflows and the automation that makes this all possible. There really would be no way to do it without using the automated algorithms that we have inside of our EHR. And again, we have found it to be a win for our patients, a win for our providers, and hopefully a win for the healthcare system. That's all we have for you today. I'm happy that you're able to join us, and I hope you found this useful. And again, thank you, James, for all your hard work on this project as well.
Thank you for your support. And yeah, it's a team effort and to do this work. And yeah, we're doing really great work. And I know we're helping people and in some cases saving lives.